Hi, everyone, and welcome to our weekly edition of What's Up, Doc. Today, we have Dr. Sudi from 360 Vascular over near Columbus, Ohio, and he specializes in chronic venous insufficiency and other vascular issues. The reason I bring up chronic venous insufficiency is because President Trump was just diagnosed with chronic venous insufficiency. And this is a disorder that is rarely talked about, if at all. It's undertreated, it's underdiagnosed on the one extreme, and then it's overtreated on the other extreme. And so this is a really good opportunity to shed light on what is CVI, but also another disease that we talk about all the time. You can see behind me PAD, peripheral artery disease. 1 in 5 people over the age of 60 has it. It's underdiagnosed. And my philosophy is that if he has CVI and he's over 80, he should be checked for PAD as well, that it's likely he has poor circulation in his legs and the arteries as well and should be checked. And that would be great to literally raise awareness for that as well. Vascular health is so important, right, Dr. Sudi?
That's absolutely correct, Kim. Thanks for having me. Uh, you know, Chronic venous insufficiency is really not talked about much at all, and I think part of it has to do with the fact that, unlike PAD, it's not discussed or even taught in medical school or training programs.
Wait, what?
Um,
Are
it,
you
it, it
kidding?
is not. And even though it's been many years since I graduated from medical school, when I have medical students rotate with me, I ask them questions about chronic venous insufficiency. And 9 times out of 10, nobody can answer any of the questions other than, oh, I have seen varicose veins. That's about it. But when they see the patients, they all are really amazed at, oh my goodness, my mother, my grandmother, I have seen this so many times. I had no idea what it was. And I think everyone understands the importance of peripheral arterial disease because it is such a powerful predictor of overall cardiovascular health. That if you have peripheral arterial disease, there's a good chance you probably have coronary artery disease. And so that's why there's a lot of emphasis, put on it. But at the same time, peripheral arterial disease, in most cases, is a disease that affects the older population. Yes, there are going to be those that are younger, but overall, it's a disease of the older population, diabetics, smokers, people with high blood pressure. Whereas CVI can actually start as early as the teenage years. You could be a late teenager up to over 90 years of age. So look at the just sheer number of people who can be affected by chronic venous insufficiency. It's really staggering.
So why is it that it's not talked about more? And when you talk about it not being taught in medical school, you're talking in the general education, not when someone goes on to specialize in like vascular surgery or interventional cardiology or the like.
Yeah, well, no, even in training programs, there is no training program that will teach you everything in your specialty. Medicine is just too vast. But if you look at vein disease in general, most training programs do not even touch vein disease, chronic venous insufficiency. They will touch things such as pulmonary embolism, they will teach deep vein thrombosis. But when you look at chronic venous insufficiency, very few training programs deal with it. It is considered not the what's the word I'm looking for? It's not considered the type of complicated procedures that you want to be doing in your training program. It is really blown off like, oh, you know what? That's like for private practice people. Let them just go out in their offices and do that. I'm here to learn about aneurysms and aortic dissections and all this major stuff, which is good. But the problem is when you go out and practice, how many abdominal aortic aneurysms are you going to see in a given day compared to someone who walks into your office with chronic venous insufficiency? If you see 20 patients in a day, you're lucky if you see one aneurysm. You will see 18 patients with chronic venous insufficiency.
Why is this so prevalent? And we should probably talk about the symptoms and what exactly it is now that we're, 5 minutes
Yeah.
into the discussion.
Yeah. So yeah, it's a very good question, and it's multifactorial. So one is the fact that it is due to the aging process. So venous insufficiency is blood that is going backwards down your veins. So the arteries bring the blood from the heart down to your feet. The veins bring the blood from your feet back up to the heart. So they have to work against gravity. And there are little valves in our veins that push the blood up towards the heart. And those valves, they just start to malfunction as we age. And it's going to start at a different age in every individual. The more kids a woman has, the higher the chance of her developing venous insufficiency in her lifetime, because those valves get damaged from the pressure of pregnancy, of carrying a pregnancy to term. So that's one risk factor. If there's genetics involved, if one of your parents has CVI, you have a 50% chance of developing it in your lifetime. If both of your parents have it, you have a 90% chance of developing it in your lifetime. Okay. And then if you do two things that human beings should never, ever do in their life, you are at risk for developing CVI. And you know what those two things are, Ken?
I can't imagine.
Those two things are sitting and standing.
Oh, well, two things that you do all day long.
Correct.
Seriously.
So we are all doing one or the other. If you sit or stand in your lifetime, you are at risk for CVI because it is due to gravity. Gravity is trying to pull everything down. And just like death and taxes, none of us can escape gravity. So you take gravity combined with the aging process, combined with mom or dad having it, multiple pregnancies, being overweight. That's why so many people get chronic venous insufficiency.
And what are the symptoms? So I imagine because one of the reasons that they came forward with it is a lot of people noticed the swelling in both of President Trump's legs.
Yes. So swelling is one of the most common signs of chronic venous insufficiency. The one sign that most people are familiar with and most physicians are familiar with are the big ropey varicose veins. Okay. Now, the one thing with the ropey varicose veins is most people and many physicians think that it's purely cosmetic. That you know what, there's no need to fix it. You know, you're 80 years old. Why do your legs need to look good at this age? But people can have painful varicose veins, and when they're really painful, then a physician may say, "Oh, you know what? You have painful varicose veins. Okay, I'm going to send you to a vein specialist and get it treated." But if they're not hurting, they'll say, "Oh, don't worry about it." But varicose veins are just one sign of CVI. When we go over the list here, you'll be amazed at some of the symptoms you may have yourself. I have CVI myself. I've had it for 10 years. So what are the signs and symptoms? You could have hip pain, groin pain, heaviness and fatigue in your leg, throbbing pain in your legs, cramps at night, Charlie horses, restless legs, extremely common. Most people, if they are diagnosed with what we call restless leg syndrome, they actually get sent to the neurologist for treatment because restless leg syndrome is thought to be due to what we call a dopamine deficiency. We don't have billions of people with a dopamine deficiency problem. It's actually a vein problem, and it's very easy to diagnose. But restless legs is very common. Ankle swelling, calf tightness, itching of the skin in your legs, skin discoloration, pins and needles or neuropathy in the feet, which people automatically assume that because they're a diabetic, it's due to diabetic neuropathy. But if you were diagnosed with diabetes a year ago, You don't have diabetic neuropathy just yet. Ulcers, 70% of wounds of ulcers on the feet are due to vein disease. 30% are due to arterial disease. So all those things are all due to CVI. And when you put them all together, people look at the list and they're like, oh my God, I have so many of those.
And so how do you know, so let's say you do have some varicose veins, they dig a little bit deeper, they perform a venous ultrasound, and I assume that that is the gold standard for testing for chronic venous insufficiency is a venous ultrasound.
It is, but in my experience, many places do it incorrectly. Okay.
Oh no,
Yes. So the venous ultrasound, if you're doing a proper venous ultrasound, it
you
will
need to be
be about,
standing up, don't you?
yes, it will be about a 45-minute to 1 hour exam. It is first done laying down because we look for clots first. You want to make sure there's no clots. And then we stand the patient up. And we have to stand the patient up because you want to introduce gravity into the equation. And you want to see, is blood going backwards down the veins? Are the valves not working and gravity is pulling everything down? That's the proper way to do it. And the vast majority of places will do it laying down. And then you don't get the information you need, and therefore you don't get the diagnosis. So you'll have a patient come in who's got heaviness, fatigue, skin discoloration, all these things. They're not standing up. The ultrasound comes back negative, and they go back to their PCP, and their PCP says, don't know, your ultrasound was negative, when all you had to do was stand them up. But it is ergonomically challenging for the ultrasound tech to do an ultrasound standing up, which is why many of them don't want to do it.
Yeah.
Now you can do it laying down.
There's got to be a standard. They have to say, I mean, if you're trying to diagnose chronic venous insufficiency, and that is the suspected issue that the patient has, then I would imagine that, you know what, ultrasound tech, you really don't have a choice. We need a proper diagnosis.
That is correct. But you also have to be educated on the pathophysiology of it. Many people treat it as a ultrasound to rule out a blood clot. So if someone has leg swelling, they will send the patient for a DVT ultrasound, which is 15 minutes long. And then they'll say, oh, no, you don't have a blood clot. I'm not sure why your leg is swollen. Whereas I would say, okay, you don't have a blood clot. You probably have venous insufficiency. You have to be stood up. Now, if you can do the ultrasound laying down, and if you see blood going backwards, down towards the feet while the patient is laying down, then you don't have to stand them up. But if you don't see it and the patient has the clinical symptoms, then you must, stand them up.
I hear this all the time. It's so interesting. You're saying that. I hear it all the time from patients. They go and they go to a vascular center or whatever, and they're like, yeah, they said, I just don't have a DVT. And I said, but what about chronic venous insufficiency? I don't understand. You need to, and then they have to go back again. It's such a waste of time. It's a waste of money. I mean, how much of an inconvenience is it for an ultrasound tech to perform both? Is it a matter? I know it's not up to them. I know it's up to the prescribing doctor, but is it lack of knowledge that the primary care doctor that is ordering it just doesn't know? Otherwise, that's what you're alluding to. So the patient has to be the knowledgeable one. The patient has to say, I mean, because even with peripheral artery disease, the patient still needs to be the knowledgeable one and say to the doctor, hey, I have claudication. When I'm walking, I think I might have peripheral artery disease. They have to do the same with the doctor when it comes to chronic venous insufficiency. Hey, I have swelling. I have some pain in my legs. I don't know if it's a DVT. I don't know if it's chronic venous insufficiency. Can you order an ultrasound for my veins where they actually look for both?
So you bring up a really good point, and part of it is knowledge on the physician's perspective. So let's say if a primary care physician is ordering the study, they will not know what to order. They'll just say, get an ultrasound. They have to specify that they want a standing reflux ultrasound. If they just say a venous ultrasound, it will be a DVT study. Now, even if they say, I want a reflex ultrasound, again, they have to specify standing. That particular vascular lab may not do it standing. That's just not their protocol. So you have two potential obstacles. One is coming from the ordering physician. The other is the actual vascular lab. The other one, which is actually a very big issue that no one wants to talk about, but I'm going to bring it up, and it has to do with money. Okay, so when you order a arterial duplex study for PAD, every vascular lab knows what that is. There's a code for that, and you do that study. When you order a standing reflux ultrasound, there is no separate code for it. It is the same code as a DVT study. Now, the DVT study takes 15 minutes. A reflux ultrasound takes anywhere, if you do it properly, for both legs, an hour to an hour and 10 minutes, about 70 minutes to do the study. And you get the same payment that you would for the 15-minute DVT ultrasound.
So the facility, just to be clear, the facility that is doing the ultrasound for President Trump ends up, and I'm sure that they're all getting paid for ample for their time, I would assume, taking care of the president, right? But let's say that he went in for his ultrasound for the veins, assuming he probably had to do the standing venous reflux. That ultrasound tech did not get paid, or does not get paid, or the facility does not get paid for the time spent to do that diagnosis.
That you're absolutely correct. That's why nobody wants to do it. That's why nobody
Wow.
wants to do it. Yeah.
So
It's a big reason.
this is a really good opportunity, especially when you're talking about how widespread this disease is. Using this as an opportunity when you have a high profile case like this, with the president being diagnosed with chronic venous insufficiency, one of the most underdiagnosed diseases, likely because there is no diagnosis code, right, for reimbursement, to say, hey, you know what? We need a code here.
Yeah, and that's a very different discussion, and that has been brought up for years and years, and it is making absolutely zero progress.
Why is that? What is the resistance that you're all facing?
A lot of it has to do with reimbursement and the way these things are paid. There is something called budget neutrality in medicine, where let's say there's you've got $100 to pay out, for all these imaging things that are done. Well, let's say for a regular DVT ultrasound, you get paid $2 for it. Well, every time a new radiology study is invented, so to speak, Congress doesn't say, oh, wow, medicine has advanced and we are going to increase the budget to $200. They say, nope, we're keeping it at $100. We're adding these new studies. That means everybody takes a cut across the board for what they're getting for those studies. So, you need to get an organization to say, look, we have a lot of patients who need these, studies, but in the whole broad scheme of things, there are more people getting ultrasounds of their abdomen or of some other part of the body than a standing reflux ultrasound. So people say, hey, I don't want my reimbursement cut for my abdominal ultrasound just so the vein doctor can get reimbursement for the legs, because I could care less about venous insufficiency. I'm interested in people with liver disease, or whatever it is.
Yeah.
So that is part of the problem with medicine. At the end of the day, it's a numbers game.
It's a disincentive actually to practice medicine. Medicine evolves, but you're going to hinder its ability to evolve if the payment or the reimbursement doesn't keep up with it.
Yeah.
Maybe
Mhm.
before they didn't have a means or even an indication that you needed to test for this, but
Right.
wow, as the practice of medicine has evolved, you've gone, oh, wait a minute, you know what? We have a better way to actually test for this. And so you need it to be included.
Yeah, you do, and I think, but that's the short-sighted outlook when a patient of, and what I mean by that, of the facilities not wanting to do the study. It's really saying, hey, I've got all these patients, hundreds of patients coming to me with heavy legs, tired legs. Many of them, they're like, I can't, they'll come in and say, Dr. Sudi, I can't do my job anymore. I work at Walmart. I work at the grocery store. I'm a cashier. I cannot stand. My legs hurt so bad. And a funny story, Kim, was when I was at Penn, I was in the cafeteria eating with one of the other physicians. He's a cardiac surgeon, and we're talking, and he was saying to the doctor next to him, he said, he's like, I may have to retire from surgery in the next couple of years. He's like, I thought I would make it to 65. He's like, I'm 57. He's like, I just cannot stand it. He's like, my legs ache so bad.
Mm.
And I said to him, I said, you have venous insufficiency. I said, do you wear stockings? I was like, pull up your scrub pants. And I just took a look, and his legs were all like discolored, were all discolored.
Oh
And
no.
and you know what he said to me, Kim? He said, he's like, that's a bunch of garbage. He's like, vein disease. He's like, that's just cosmetic.
Oh
That's the
wow.
cardiac surgeon saying that to me. And 6 months later, he paged me and he said, hey, do you remember when we were having lunch in the cafeteria? It's like, would you mind seeing me? And then we fixed his legs, and he became a believer. He was like, oh my goodness, why didn't I get this done years ago? He's like, now I understand what people talk about.
That's incredible. What a story. And so let's talk about the treatment
Mhm,
for it, because my dad ended up with chronic venous insufficiency,
mhm,
and his treatment was, at first, I'll just go through it, what he
mhm,
went through and what the treatment process was, and you can affirm what he went through, or you can say, hold on. But they first started out with the ankle compression socks, then they went to the knee
mhm.
high compression socks, then they went to the thigh high compression socks, and then he was pretty much wearing pantyhose.
Yes.
Yeah, that was really masculine. My dad, he's not Joe Namath, although he
Yeah.
did pick off Joe Namath in high
Yeah.
school. It's his favorite story. But needless to say, he went from there, nothing worked. This was over the course of about a year and a half. He went through this process. And then he went back to the doctor, and the doctor said, okay, well, we're going to go in and do a venous seal, where they go in with the super glue and they just plug up the faulty veins, right? Because, and you can explain, I'd love you to also explain how the veins, there's duplicates. So you can ablate certain ones and how that works. But he had four venous seals.
Mhm.
So two in the front, one on each
Mhm.
leg, and then
Yep. In the
one on each leg in the back.
Mhm,
That made his symptoms worse, which was interesting.
mhm,
And so then he went to, and I can name the doctor because he was our MacGyver of the year for 2024 through the Global
mhm,
P.A.D. Association. It's Dr. Miguel Montero Baker, a vascular surgeon in
mhm,
Houston with Hope Vascular. And my dad said, nothing's working. I'm tired of these heavy legs. It's now, we're 2 to 2.5 years into this. I can't walk in the morning anymore. What can I do? And he said, oh, just take some Vasculaira Venexa, and literally all the swelling in his legs, the heavy legs, went away.
mhm,
It was the most incredible thing. I don't know exactly how it works. It's simply over the counter stuff,
mhm.
but it was like a miracle. And even more is he just had his hip replaced, and the doctor was blown away that he didn't have all of the swelling that a typical patient has. And that's because he felt that he maintained the dosage of the Vasculera.
Mhm.
So I'm curious from your perspective because everyone's wondering, okay, so what's the prognosis for President Trump? Is he going to be wearing compression socks? Is he going to go in for a venous ablation? Does it indicate anything else that might be going on in his body? What are your thoughts?
So, for President Trump, I can't comment on his specific case since I don't know the details. But what I can tell you, Kim, in general, is the first thing we want to do is get people in compression stockings. And it's not just those who have been diagnosed with CVI. I think everybody on earth should be wearing stockings. I am a
Really?
big believer in stockings. Everyone in my office wears stockings. I have been wearing stockings I started in my mid 20s. So for 25 years, I've been wearing stockings. And because none of us can escape gravity, as I mentioned, and that plays a big role. And so the goal is to hopefully not develop chronic venous insufficiency. Stockings may not necessarily prevent an individual from getting it, but they can slow down the progression of you developing symptoms. So we want to start it, I think, at a young age, maybe college years. Or I don't know the exact age, but so I'm a firm believer with stockings. Now, the other
And you're
things,
talking compression stockings, but
compression
light
stockings.
compression, a very
I'm so,
light compression.
yeah. So I give all my patients, and what I wear myself are medical grade stockings. And medical grade is considered 20 to 30 millimeters of mercury compression. Now there's lower compression, 15 to 20, and I think that's probably fine too, especially in young individuals who don't have any problems. But I personally, even before I developed a venous insufficiency, I'd been wearing 20 to 30. So, but and knee high is really all that is needed. Now, when people start wearing stockings, they don't like it, and no one really wants to do it. But I equate it with wearing a seatbelt. When they mandated seatbelts, no one wanted to, wear the seatbelt. But now it has become second nature for all of us. And so with the stockings, if you start at a young age, you will get used to it. It took me about 6 weeks of wearing it every single day to get used to it. And I didn't like it, but I got used to it. And now I have a hard time going 1 or 2 days without my stockings. But stockings first. Weight loss is very important. If someone is overweight, the heavier a patient is, the worse their legs will feel. It's simple physics because of the downward force of their body on their veins. As someone gains weight, there's more downward force on their leg veins, and so the blood is forced downwards, and their legs feel worse. Exercise. When you exercise, your calf and thigh muscles start moving and they start contracting and they start squeezing your veins, and the blood moves up to the heart. So that also helps. Leg elevation. And leg elevation has to be above the level of the heart, not just sitting on your couch with your like at a right angle with your leg out. That's not leg elevation. It really has to be above the level of the heart. So those are the conservative measures. And then there are other things that you could do, what we call alternative therapies. So things such as Vasculera that your father got. Vasculera is what's called a flavonoid. A flavonoid is sort of plant-based. It is what it's designed to do is veins, when gravity pulls the blood down into the veins, they become distended. They become wide because they're filling up with blood. And so what a flavonoid does is it is supposed to increase the tone of the wall of the vein, meaning it makes it more rigid so that it can't dilate. So the vein actually stays narrower. And if it stays narrower, then gravity can't pull as much blood down into this narrow vein. And so the blood has to go back up. And so that is the premise of using it for venous insufficiency. The reason why it is not recommended more is because of its very mixed reviews. It will work for some people. It's great that it worked for your dad. But I will tell you, if I mention it to every patient, out of 100 patients, it may work for 7 or 8. So I tell them, look, you can try it for
Really?
2 to 3 months. If it doesn't work, stop it. So there is
So do you think
literature
the
on it.
ones, do you think that there's so many patients that are not, especially if it's not a general prescription,
Yeah.
even with prescriptions, a lot of patients are not, they skip a day, they're just not diligent versus, my dad's captain dad, he was in the
Yes.
military, Navy
Yeah.
captain. And so if you as the doctor tells him to do something, I mean, he adds it to his regimen, he makes sure it's in his little pill box for every single day. And he has his morning ritual where he has his breakfast, he walks into the kitchen, he grabs his pill box and he takes
Mhm.
all of his pills.
Yeah. And so you bring up a very good point. All those things come into play, but it is very hard from a physician standpoint to know, are they truly taking it every day? Even when we do the stockings, every insurance company requires that patients do 6 to 8 weeks or sometimes more of stockings before you can do any procedure. And when a patient comes back and says, yes, Dr. Sudi, I've been wearing my stockings, I have to take it at face value.
I know they need to have
Sometimes you
sensors
can
in there.
tell they're not, but
You know that, I mean, it's so hard to get started in wearing them. I mean, our network has 12,000 patients, and I'm going to tell you that um, if you're telling them to wear those stockings, they're not.
they're
They
they're
really
not.
aren't.
They're not. But
They're
what can
uncomfortable.
But the one thing that I have found, my conversion rate to stockings for patients has been pretty high,
That's
um,
good.
because I think when I
You're pretty convincing.
when I explain it, I show them my own stockings.
See, well, lead by examples. That
Yeah, so
works.
I lead
Yeah.
by example, but also telling them that, look, it will be uncomfortable. I don't sugarcoat it. It will be uncomfortable. It is summertime. So people ask me, they're like, Dr. Sudi, they're like, you mean to tell me you wear these things in the summertime? And I tell them, I do. And here's how I do it. I say, on weekends, I've got my shorts on, I've got my stockings on. And yes, my kids will make fun of me, but I have them on in the house with the air conditioning. Now, if I'm going out on Saturday at 2 p.m., from the moment I wake up until I leave the house at 2 p.m., I will have my stockings on, and then I remove them and I don't wear them for the rest of the day. But at least my legs got 5 to 6 hours of compression.
Yeah.
So, you have to be real. We also have to be realistic. It's 100 degrees outside. We can't expect patients to wear these things, but also, give them some advice on, how they can wear it, even if it's just for a few hours a day.
I mean, if it's 100 degrees, that is pretty significant. If you going outside and having to wear the stockings, but I wear them often. I wear the 15, and I wear them a lot. I have my socks from flow-socks.com. Jill Somerset,
Yes.
who's
Yeah.
an RT, she has these really cool ones with the arteries and the veins all on there. So if patients want to go there and check those out, those are awesome. Those are like a little hug on your leg. So when I'm not wearing those, I do actually miss wearing them because they feel nice and secure. And I also wear them on the plane as well.
Yes. Yes. Yeah.
But what about for PAD patients? Supposedly they're contraindicated if you have arterial disease and venous disease.
Yeah. So yes and no. So that is actually, Kim, what I have called VAM disease, and I have a piece that just came out on VAM disease, and VAM disease is venous and arterial mixed disease. Okay,
Mhm.
and it's just an easy way for patients to remember it. And compression stockings are not necessarily contraindicated in patients with PAD. It depends on the severity of PAD, because we know that you can have very early PAD, some mild claudication, it's probably okay to wear, to wear stockings, because many patients will have both, and the stockings will help with the venous component of the patient's symptoms. And when a patient complains of pain, you can have claudication pain, but you could also have pain from venous insufficiency. So how do you separate that out? Do you say that, well, 40% of your pain is due to venous disease and 60% is due to PAD, or is it the other way around? There's no way to quantify that. So I tell patients, look, your PAD is maybe not that bad. We don't need to do any intervention yet. You need to be on an exercise program. But they say, Dr. Sudi, I can't do an exercise program. My legs hurt. Now, when you look at their legs, if their legs are swollen, they've got a decent amount of venous disease, because PAD doesn't cause swelling. Vein disease is swelling. So if you put the stockings on and their swelling comes down, their heaviness improves, the tiredness improves, then that gives them the ability to say, oh, you know what? I can start walking more. And what is walking good for? It's good for your PAD. So that's how you get them on an exercise program, and you improve the venous symptoms, and you try to, improve the PAD side.
How do you handle diabetics who are supposed to wear diabetic socks if they have chronic venous insufficiency?
So with diabetics, I go with a lower compression. I go with the lower compression. And now there's some diabetics where it's just contraindicated. You're just not going to put stockings on them. But that's where the physical exam, the results of their arterial duplex, their venous ultrasound, and I'll determine, do I think it's safe for them to wear stockings? And if it is stockings, what strength? It's not that, we stock all the stockings, all the different strengths of stockings. So I can, give them, whatever strength, that I want, and then say, okay, this one is a much lighter compression. Something is better than nothing. This will be, give you some support on the venous side, but we don't want to give you too much because you have bad peripheral arterial disease. So that's kind of how we play it. And there are going to be those patients who you just can't give them stockings at all. Okay. And if their venous disease is bad enough, then we go ahead and treat it. We just document it that, hey, you know what? We can't do stockings in this individual, but their disease is severe. We're going to treat it. And then, and then you treat it, you see the improvement, and then you sort of see, okay, now that you've treated the venous side of things, your pain has improved. Whatever pain you have left over is now due to the PAD side of things. And we also look at the conservative measures for PAD, the walking, using medications like Solastazole to improve flow. So you have to tackle it from both ends.
Yeah, I think when it comes to vascular, you can't be myopic. You have to be holistic in your approach, because
Right.
it's likely most patients do have at least a little bit of both. I mean,
Yes.
especially if they're over age 50, especially if they're diabetic, but even more so age 60, where 1 in 5 have PAD. What's the percentage of people, did you say, that have chronic venous insufficiency or are thought to have them? I mean, I know it's in the millions, right?
Yeah. So on the low end of the spectrum, 1 in 4 adults will develop CVI in their lifetime. Okay. But if you add in other risk factors, such as being overweight, having multiple kids, and then if you're in an occupation where you're sitting or standing all day, which is a lot of us, and you include in genetics, then, like I said, it could be up to 90% of the population, depending on the population that you're studying. So for a condition that affects literally billions and billions of people around the world, it's still amazing to me that it's just not taught.
And so for those that are wondering, I mean, everyone, are we making a mountain out of a molehill when it comes to a diagnosis for the president of chronic venous insufficiency? Or is there more to it that we should be worried about for a president having this disease?
So that's a really good question, and I have to say, Kim, as I've been watching the media, one of the things that I've really been a little disappointed with in some of the coverage is everyone saying that, look, the president has this, it's a benign condition, it's really nothing to worry about, kind of wear some stockings. To me, that's exactly the sort of attitude that leads to all of this being ignored. Now, I understand what they're saying. Yes, in the whole broad scheme of things, venous disease is not something that is going to affect your longevity. It is not going to kill you, but it really affects your quality of life depending on what stage you're in. So the president, if he has a little bit of ankle swelling, it may not bother him at all. He'll be perfectly fine. Put some stockings on. But look at all the people that we see who have skin discoloration, who can't stand, who have ulcers. You look at the people who go to wound care centers. A lot of those wounds at wound care centers are all venous in origin, and they don't get treated. They just get one ointment after another, one dressing, after another. And so, yes, even those patients, they're not going to die from their vein disease, but what kind of quality of life do they have? So to me, it is not, it's something that can start out very benign, but when you look at all the stages, it can really greatly affect your quality of life.
At what point do people develop the venous ulcers? We've had several patients that have had the venous ulcers. I mean,
You know,
is there a certain stage of it? Are there certain risk factors that in which you see it being more prevalent?
Yeah, so anyone can develop ulcers. I when I educate patients, I say, look, it's not that everyone's going to develop ulcers, but there are 6 stages of vein disease, and we have a classification for it. It's called the CEAP classification, CEAP, if people want to Google it. And so the first stage of vein disease is purple spider veins, which are purely cosmetic. And then the second stage are the ropey varicose veins. And that's the one that most people and physicians are aware of. The only thing with ropey varicose veins is that only about 1/3 of patients actually develop the big ropey varicose veins. 2/3 of patients develop the things that you cannot see. You cannot see heaviness or fatigue or restless legs as a PCP looking at a patient. Okay. The third stage is ankle swelling. Fourth stage is skin discoloration, where you get that brownish discoloration of the skin.
Mhm.
And then the fifth and sixth stages are ulcers. Okay. Now, it can take maybe 40 years to go from stage 1 to stage 6. But what amazes me is in 40 years, not one physician addressed venous disease. How do you go from stage 1 to stage 6 over 40 years and no one says anything? That means everybody's missing it, not just
And it's
the
something that you can stall
PCPs.
progression of.
You can stall, at least slow down. Yes, you can. When we get ulcers, we tend to see it more in obviously people with diabetes, people who are really overweight, especially morbid obesity,
Mm.
just because of the downward force. People who are just really very sedentary. Um, um, this isn't really don't want to get too much into other vascular conditions, something called iliac vein compression syndrome or May-Thurner syndrome. Those are also people where they have a higher propensity for getting ulcers. If you've had a history of a blood clot, and you've developed something called post-thrombotic syndrome, which is the long-term complications of DVT, you're at a higher risk for ulcers. So there's quite a few, but fortunately, I think the vast majority will not proceed to that. But we just don't know who will get an ulcer and who won't.
Now, when you're talking about the minimally invasive treatments that I mentioned, even
Mhm.
with my dad, when you're talking about the minimally invasive treatments for once you've gone beyond conservative, what are the different options out there and what are the indications for those options, such as the venous seal, such as the vein ablation? I know that most doctors no longer strip, so but strip veins.
Yes. But you'll be surprised every now and then, I'll see a patient who they had their veins stripped. And I said, well, when was it done? And they'll say last year. And I'll be like, oh my God, vein stripping surgery, which I have done. The last one I did, I think was 2001 or 2002. But that is rarely done. Now, maybe in some parts of the world, it is, but here in the US, it's rarely done. The what's considered the gold standard is vein ablation or thermal ablation. And there are two kinds of thermal ablation, laser ablation and radiofrequency ablation. And they're both, pretty equivalent. So it's really up to the physician as to his or her preference on which one they want to use. And vein ablation has about a 98% success rate. So it's a very good success rate. But it's not 100%. So that means there is a 1 to 2% failure rate where the vein may open up again, or you just don't get good closure of the vein. There are other things that have come out on the market, such as VenaSeal, where you're using glue. There's something called Mocha, where you're kind of putting like a chemical, and you have this sort of little rotor device that sort of spins and causes some inflammation to the vein wall. All of these different modalities are essentially trying to do the same thing, and that is to close the vein. Whether you're closing it with heat, like a laser or radiofrequency catheter, or you're using glue, like in a VenaSeal, the end result is is the same. But some of these modalities are better in some circumstances, and it's really dependent on the physician as to which patient they want to do that on. Some of the side effects may be less. One of the things with vein ablation is we have to put a lot of anesthetic in the leg, something called tumescent, where we inject a lot of saline that's mixed with anesthetic into the leg. And so you're poking the patient with several bee stings of lidocaine all the way down their leg and injecting this saline. And that can be uncomfortable for the patient. VenaSeal, you don't have to do that because you're not using heat, you're using a glue. So that was one of the reasons for the development of VenaSeal, that you didn't have to poke the patient, all that much. But then there are downsides to that. So I think a lot of it also has to do with the physician's experience, what he or she maybe was trained with, or what they feel comfortable doing. At the end of the day, you want to make sure that you have good vein closure consistently and long term, whatever route that is. Now, are you going to have patients who don't get a good result? Absolutely. And that's with everything that we do in medicine. That doesn't mean that the procedure is bad. But when physicians talk about venous insufficiency, we are talking about blood going backwards down the superficial veins of the leg, what are called the saphenous veins of the leg, which are right underneath the skin. But you can also have blood going backwards down the deep veins of the leg. And the deep veins are where we get blood clots. But those veins, like the femoral vein, the popliteal vein, also have valves in them. And the symptoms of deep venous insufficiency and superficial venous insufficiency are exactly the same: heaviness, fatigue, swelling. So on that standing ultrasound, if I get a patient who has reflux in the deep veins and the superficial veins, I say, look, all I can do is treat the superficial veins. Okay. And if your symptoms improve, then most of your symptoms were coming from the superficial side. If you come back and say, you know what, Dr. Sudi, my symptoms only improved 50%, then probably the rest of your symptoms are coming from the deep side. And I cannot go and close off your deep vein. That would be like giving you a permanent blood clot. So there's not a lot you can do for deep vein insufficiency unless there's a blockage like a May-Thurner or something like that.
So that's where I'm wondering. So my dad's were all superficial, that he ended up getting the VenaSeal. So it may be likely, and it might be worth going back and having another venous ultrasound, a standing venous reflux,
Mhm.
to just double check and make sure it likely is deep vein. And then is he just SOL? I mean, at least the Venexa is easing his heavy legs a little bit,
Yeah.
but
It could be. The other is, what is the extent of closure? Typically, we want to close the vein throughout its entire course. Many times, again, depending on the physician, he or she may close the vein just halfway down the leg, from the groin down to the knee. But the saphenous vein goes all the way down the leg. And so we want to close as much of it as we can. And it's not
Mhm.
uncommon where patients uh, they come back and their issues are coming from the segment of vein that was not closed from the knee to the ankle. And because that was never closed, that's why they continue to have symptoms.
Gotcha.
So that's something that has to be looked at. I have seen the wrong vein being ablated. So we do the ultrasound and they say, oh, I had my great saphenous veins ablated. And then we do the ultrasound and it looks like it's still there and it's, never been touched. Now there are some reasons that are very legitimate, that can, account for that. But sometimes, maybe it was just the quality of the ablation.
Well, wow, this is such a valuable discussion. This is going to be like the handbook for chronic venous insufficiency. Um, I want to close out and hopefully, do you feel like we covered? I mean, we covered a lot of different things. Do you think that we hit all of the keys, and or is there something else that you want to mention that you think is really important for people?
You know, I think we really covered a lot. When it comes to venous insufficiency, I think people um, uh, need to keep in mind that there is a very good chance that we are all going to get venous insufficiency in our lifetime. Whether it's something that will need to be treated with a procedure, that's a different story. So in general, we don't want to do unnecessary procedures on people. So if there are things that we can do to minimize our chances of having to get a procedure later on in our life, why not take it? So to me, wearing stockings is part of good vascular health. I have a family history of venous insufficiency. So that means I have an over 50% chance of getting it. I'm standing in the operating room, so my chances are pretty high. But I've done pretty well so far just with stockings. So maybe I'll be able to go the rest of my life and not need a procedure. And so that's what I want people to really understand, that all those pictures and stuff that they see, they don't have to be like that, and that you can slow that progression down.
Fantastic. So, in summary, it sounds like number one, varicose veins. If you have varicose veins, if you have those little spider veins, the same thing, you need to get checked. You need to have a full venous artery, I mean, excuse me, venous ultrasound, standing
Yeah,
ultrasound.
yeah. With the spider veins, that's the very earliest stage. Chances are the ultrasound is going to be negative, and spider veins are also just part of the aging process, but they're purely cosmetic. One other thing, I failed to mention is that venous insufficiency can increase your risk of getting a DVT. So if you have significant venous insufficiency and you go on a long plane ride and that blood is just pooling there and you don't wear compression stockings, well, that's how you end up with a blood clot in your leg. So untreated vein disease can lead to clotting, or at least increase your risk for a DVT.
Interesting. Oh, wow. So we need to make sure that President, I would love if there was a way to get President Trump a pair of Jill Somerset's flow socks. That would be
That would
huge.
be
That would be
fantastic.
fun. I
Yeah.
think that would be amazing. So if you're out there and you're listening, send it to Pennsylvania Avenue. Go onto her website, flow-socks.com, and just get those compression socks, the flow socks, flow-socks.com. She's not paying me, by the way. I just
Yeah.
absolutely, she's so talented. And
Yes, she is.
the socks are amazing. I mean, if you're going to wear them, those are at least really comfortable. Those are the ones that I find, even at the 20 to 30 level, they're like a little hug around your calf. So they're actually fairly comfortable, and the material is really, really nice versus some of the ones that you get from some of the pharmacies out
Right.
there.
Yeah.
Have a very rigid material, which is not really that comfortable. But in our last moment here, do you want to just summarize the key takeaways for everybody?
So, key takeaways with venous disease is that it is a condition that really affects a wide age group, and it will affect many of us in our lifetime. Keep in mind that many physicians may not be familiar with how to diagnose venous insufficiency, and so if you're going to your doctor complaining of heaviness and tiredness and cramps, and they just tell you, oh, drink some more Gatorade or drink some more water, you want to mention that, hey, could this be vein disease? And if so, you need an ultrasound that's done while you're standing. Compression stockings, again, I think everybody on planet Earth should be wearing wearing stockings. So hopefully I can convince people of that. And then just keep in mind that if you need treatment, it is not a life-threatening condition. You have time to do your homework. You have time to do research. Ask questions. It is not something that you need to jump immediately into as far as procedures are concerned.
And Dr. Sudi, tell everyone where they can learn more about CVI, because I think you have the best information on CVI on the planet on your website, as well as on your YouTube channel.
Yes, that's correct. So my practice website is 360vascular.com, but I also started a blog over a decade ago called gethealthyveins.com, which is all about deep vein thrombosis, pulmonary embolism, and chronic venous insufficiency. So that is really a resource that's also used by physicians to learn about these conditions, and then my YouTube channel as well.
Yes, the YouTube channel, youtube.com/the @
And
And
then
is
Dr.
it just
Sudi. Yeah,
Dr. Sudi?
DRSUDI. Yep.
Perfect. Make sure you subscribe to his channel. Make sure you like this video and also subscribe to The Way to My Heart on YouTube as well, youtube.com/the Way to My Heart. That's our 501c3 for the Global P.A.D. Association. But thank you everyone for joining us. We really appreciate you. Hopefully you'll take this conversation for what it is. This is not a political discussion. It is simply having the opportunity to use a high profile case for chronic venous insufficiency to spread awareness for it, which is really important. It is widespread. And as Dr. Sudi mentioned throughout this entire discussion, you might be the one teaching your doctor about it. Thank you, everyone.